Hello, I'm Colin Davidson, the president of the College of Optometrists, and I'm joined today by Raymond Curran. Raymond's head of optometry services in Northern Ireland, and it's a great pleasure for me to be chatting to Raymond because we studied together many years ago at Aston. And really, we wanted to spend a bit of time just talking about how optometry services in Northern Ireland have coped during the COVID pandemic. So Raymond, welcome. It's great to see you. Maybe you could just give everyone a little overview of your current role within optometry and ophthalmology in Northern Ireland.
Yeah, thanks, Colin. And great to see you. And yes, we go back some time now, further than we care to admit, I suppose. So my current role is Head of Ophthalmic Services for Health and Social Care Board. The Health and Social Care Board, the board, I'll call it, is the commissioning organisation, so in charge of arranging for the provision of all eye services. So that's all services in health and social care, and my role is for provision. So I hold the contracts for primary eye care, optometry, general ophthalmic services and enhanced care, and then I'm lead commissioner for ophthalmology services. And this is great because it allows me to try and integrate services to join the dots, really, I suppose, and create an enabling environment where eye care is delivered across a continuum. So that's my role currently, as you say, optometrist by background, but a different role now for me.
Okay, great. No, thanks. It's just good so everyone knows kind of how you fit into the delivery of service. And I understand that during COVID you've managed to keep quite a large proportion of practices opening to provide care. So what have the practices been doing to deliver eye care services during the pandemic so far?
Yeah, so at the start, we made the decision. So on the 24th of March, we took the decision to suspend all routine eye care in primary care, but we allowed for the continuation of essential and urgent eye care. Now, like the other regions, the essential element of things we left deliberately open, not to abuse the definition of it, but to give clinical and professional guidance as to what might constitute essential. My essential, Colin, is different from your essential. And so we thought professional advice and guidance around that, judgment around that would be useful. The urgent eye care, we have a regional, and when I talk about regional, I mean for all of Northern Ireland. So we have a regional, what colleagues maybe across the UK would know as MECS, but we call it a primary eye care assessment and referral service. So we have that in place, and we allowed for the continuation of that. In all of that, then we wanted to encourage virtual where possible and face-to-face only when absolutely essential. And that's after having screened against current case definition and ensured that the patient needed to be at a face-to-face. And about 60 odds, maybe mid 60% of all of those essential and urgent eye care things. And the essential part could be dispensing and repairs and replacements, so it's not just sight tests, etc., are virtual. Now, what we didn't do strategically was ask the majority of practices to close. We allowed that they would remain open and provide the essential and urgent. And the vast majority did. So with 271 contracted practices and 270 stayed open. That was to allow them to avail of the financial support scheme. And the two elements around application for that financial support scheme were either to continue to provide essential and urgent services or agree to be redeployed into the wider HSC, Health and Social Care. We call it NHS, you'll know it as. And so if they were agreeing to, let's say, go and work for pharmacies delivering medicines or to make themselves available to other elements, then that qualified for the temporary financial support scheme. So the majority did. The activity is about 65% virtual, as I say. On the essential side of things, it's about 50-50, but the urgent care brings up to about 65%. And we see that as a direction of travel. So the majority are doing that. The essential is a little bit administratively clunky in that it's a prior approval approach, so it goes through my team of advisors. But I think that ensures that we have a consistent approach and ensures that we can give guidance and support to practitioners on what they might see as essential. And there's where we are. It's creeping up very slightly. We're not sure of the appetite as we come out of lockdown, what the public attitude towards eye care would be. We're very aware on the secondary care side of things that people are not presenting for some of their time-critical treatments around time-critical glaucoma and macular and some of the diabetic eye treatments. And we've put out videos and selfie videos, etc., to try and encourage appropriate. So we just don't know what the appetite will be and the societal behaviours will be. But we think we've got the infrastructure in place to be able to cope. There'll be major challenges, which I'm sure you'll come to. But where we are is the majority have continued to provide a level of essential and urgent eye care.
I think that's the thing, isn't it? To really do all we can as optometrists to prevent avoidable sight loss, and the stories that you hear of patients with macular conditions, diabetic conditions, avoiding appointments because they're worried is a concern. But I think if we can reassure that our practices are safe environments, then that's really, really great, isn't it? I think one of the other things that has worked well has been how independent prescribing optometrists have fitted into the scheme of things. Is that something you've felt has worked well?
Yes, I do. So while I said that we didn't insist, and I'm not sure I have the legal powers to insist that practice would have closed anyway, but while we didn't do that, we encouraged locality-based clustering of practices. Couldn't mandate that, but that has happened. So in a location, a town of maybe 4, 5, 6 practices, they tended to cluster themselves informally. The board would facilitate that up to a point, but informally through WhatsApp groups or whatever. And ideally, they then clustered themselves around an available IP. And what that meant is that they could rota themselves, they could build in staff resilience, they could protect their own well-being and that of their families by not being on the premises all the time, but that an IP was available. And very much, it was a lot, Colin, of what we're doing at the moment, as you'll know, is the strategic direction of travel anyway. It was the policy direction of travel anyway. It's COVID has just pushed it on that a little bit faster. So out of adversity, there will be some benefits. And the main benefit is that we will be able to modernise the non-sight-threatening acute eye care provision through NI pairs, and we will be able to use the skill sets that exist within primary care and secondary care with IP qualified to take on, see and manage more of the conditions that previously would have come into the acute hospital setting. So yes, they've clustered round at a locality base and used the skills of the IP to keep people to reduce footfall into the acute sector setting. Yeah, it's been very helpful.
That's really, really great to hear. I mean, the whole thing of maybe trying to work around clusters seems to be a common theme and seems to work incredibly well. But of course, there has been challenges as well, haven't there? And how do you feel the optometrists that you've worked with have responded to that?
I've been very heartened, Colin. I've been very heartened that they've embraced. Now, each and every one of us in society has fear, anxiety on a personal, on a family, and other level, and every one of our optometry colleagues will feel the same. But they've really stepped up to the plate and said, "How can we make a difference?" And that's usually in their practice, in their in their mode of operation, etc. But very many of them have volunteered to be redeployed into wider HSC. Now, we haven't actually needed that. But they've made themselves available, and they have on a lowish level, I suppose. They've been, so some of the domiciliary providers have been using their infrastructure, and I mean vans, to deliver medicines to shielded and vulnerable groups. This has been very welcome. Others have made themselves available. So IPs, for instance, that you've said, have made themselves available to go and work in eye casualty. As it happens, for the reasons we mentioned, secondary care services have been a little bit quiet, and that's given good opportunity to reset and reprioritise, etc. So we haven't had to do it, but people have definitely made themselves available. We got them early. The board were pleased to and the college were instrumental in this in getting key worker status recognition for the primary care workforce. And we got them, I know it sounds a little bit low level, but we got them stickers for the car, key worker, etc. Because when we were trying to reduce unnecessary travel, some travel was essential, and I think that helped. On the IP side of things, we have anyway what we call HS21, so prescription forms, and we definitely think this is the way forward, that more people will be dealt with safely and appropriately in a primary care setting. So big challenges, but also a big appetite and willingness to step up and use the skills that are there. We haven't quite landed it yet, but it's given us an opportunity to look at other elements of how we might fit into wider, again, HSE reform. So headache and neurology clinics, they would like an opinion on a disc, etc. We're working on pathways for that. Uvetics, who might only require, and it's an important part of their management, just to check for cellular activity or check the pressures. Those sorts of things we think probably don't need to go into the acute setting all the time. And indeed, yesterday I was part of a Microsoft Teams meeting with one of the trusts, and we saw a very innovative home OCT for monitoring of AMD. I don't know the economies of scales on home, but I think we'd easily put that same technology into a primary care setting and start to harvest some of the very good clinical information that could help manage people without going into the secondary care. So challenges, but also very good opportunities, I think.
Yeah, I mean, absolutely. You mentioned earlier that things have had to change and change quickly, and certainly there are some good things that we've been able to incorporate into our practice that do present opportunities for greater services for our patients going forward. So it's really probably a difficult question to ask, and I appreciate that. But everyone's really, I think, wanting to know when maybe services might be up and running again as the phases of the pandemic carry on.
Yeah, everybody is, Colin, wanting to know that. Patients, we think, want to know that. The profession certainly wants to know it. And also the system wants to know it. Our minister wants to know, when can we safely re-engage services? We talk about rebuilding of services, and we're working through a process right now as we speak on how we can safely start to move from what we'll call our red phase into amber, and what enabling environment needs to be put in place for that. There's two key enablers for me, I think, they're not contingent on actual service delivery, but they would certainly create an enabling environment. One is a little bit of clarity around the temporary financial support scheme that we have in place, which has been very positively received by the profession to ensure that we have a sustainable workforce and infrastructure to deliver service going forward. And the second is the availability of PPE. Now, whether that PPE is funded from within the supply chain or self-funded, it does matter, of course, but we know that PPE will be required. So once we have that, once we have clarity from the health protection teams from Public Health Agency here in Northern Ireland, and how that then relates to the overall epidemiological modelling around R numbers, around numbers of deaths, numbers of infections, etc., then we can start to ease. And I think that easement isn't too far away. You might say, what are the various steps then? So right now we've got essential and urgent. I see then as we move to phase 2 of that, or 1B if you like, into the amber phase, then I think we'll be able to go to routine examinations very soon. I hope very soon. Probably routine symptomatic. I don't mean COVID symptomatic, I mean asymptomatic, and not routine recalls, etc. Because don't forget the same capacity challenges that we're facing in secondary care, reduced numbers going through with social distancing, with cross-infection control, with PPE. The same challenge will exist in primary care optometry, and so capacity will be down. And so we have to try and manage that. And we'll be seeking some sort of preparedness. We have surveyed the profession on their level of preparedness around PPE, around cross-infection control measures, around minor modifications to practice. So we think the preparedness is fairly good. We think there's still concern out there, but we think everybody, society would like to get back to a degree of normality when it's safe. So phase 1B will be routine, not aerosol generating, and not, I'm afraid to say at this stage, because we need to protect the vulnerable members of society, not routine domiciliary eye care. That's going through a process right now. We'll put a submission to the Minister, and if he's content, then we would like to start easing that, and then move towards the other elements. We'd like to be able to, because of the financial support scheme in place, we'd like to be able to prioritise HSC or NHS patients. We understand that's difficult because we have a mixed model of economy for primary eye care, but we'd like to, so we've paid up front basically for activity that hasn't yet taken place, and we'd like a degree of cooperation really, and would appeal to practitioners to try and do that. And we'd like to have some sort of prioritisation type approach to that. Those who are most in need, really, we'd like to move towards that. So it's all in preparation, Colin. You'll not press me on a date, I know, but I can assure anybody who's listening, not sure when this is going out, but we may have opened by then, but I think it'll be within weeks, not months, put it that way.
Yeah, I appreciate. I mean, there are so many safety considerations that we need to have before we look at that. But yes, so thank you for that. I suppose just to finish off, it has been a difficult time for all of us. Are there lessons that you think or hope that could be learnt and we can build on going forward?
Yes, I haven't seen an appetite like it. It was our strategic direction of travel anyway, collectively. So we have a Northern Ireland eye care network. And you mentioned at the start there, Colin, our principal aim is to reduce avoidable sight loss. That's what we're all working for. So that's all stakeholders, primary, secondary, community and voluntary. Everybody has a voice in this network, and that's our principal aim. What this has done is absolutely make us integrated in that united approach to delivering eye care. And so while we're strategically, we have a policy document here in Northern Ireland called Delivering Together, and very briefly, the major commitments around it are to promote self-care where possible, and so we would like to move on that. But the main thing for us, I think, is to expand capacity and capability in primary care. In other words, switch more into the primary care setting where safe and appropriate, improve the interfaces between primary and secondary care. We're very good at that anyway, I think, because we're very good IT platforms for referral for advice, and for being able to access a thing called the electronic care record. So our IT platforms enable that interface. And the fourth thing is about improving the pathways within the whole system. So all of those were where we're going anyway. COVID will definitely bring us into a space where it'll be virtual where possible, face-to-face only when necessary, and maximising resource within the whole, the totality of the resource. So using, we've heard it before, right person, right place, right time. So I think it's pushing us that direction where we're going anyway. But I've never seen the appetite as good across the sector. So secondary care colleagues who mightn't always have seen the role that primary care might are now starting to think, how can we get primary care optometrists to work with on this? Of course, part of that is driven by a secondary care agenda that needs to manage demand against reduced capacity. And what I have to do in terms of that enabling environment is make the secondary care folk aware, colleagues aware, that the same reduced capacity will be impacted on primary care. And that's where we have to move towards virtual where possible. And we've had very good innovation. We've got loads of innovation. You asked me if there's anything good come out of absolutely good examples of innovation. And it could be simple. Our local glaucoma clinic introduced a drive-through IOP check with eye care. Simple, but patients loved it. It reduced footfall. And I think once we can start putting more kit, more technology, more infrastructure in place in primary care that links directly to secondary care, then I think we can start moving on our strategic agenda and push it on. So out of adversity has come very good innovation, and I think we have to capture that, and we have to capture the behaviours that people are exhibiting. That change, that collaborative approach, I think is going to be very important.
Yeah, I would echo that as well. I think the collaboration that we've seen in our college discussions between primary and secondary care colleagues has been fantastic. And if we can build on that, it can only be the patients that benefit from it. So yeah, absolutely. Raymond, I know you're incredibly busy, so I really appreciate your time this morning and the insights that you've given us into the work, the engagement that you've had from your colleagues in Northern Ireland. So thanks for your time, and hopefully we'll speak again soon.
My pleasure, Colin. Good to see you, and congratulations on your presidency, and I wish you all the best. And we're here to support you.
That's good to hear. Thank you very much.
Bye bye.